presentation today about vitamin D deficiency in knee osteoarthritis patients and its association with obesity and knee osteoarthritis in Saudi Arabia. As all know, vitamin D deficiency is usually defined as serum 25 hydroxyvitamin D level of less than 20 ng per milliliters. It's quite common problem worldwide. It's highly prevalent in condition present in approximately 30 to 50% of general population. It's considered as a silent epidemic condition. In some communities, the rate of vitamin D deficiency ranging from 50 to 80%. It's more prevalent in elderly with a rate of 50 to 60% of older population in the world have unsatisfied level of vitamin D. The main cause of increased deficiency of vitamin D in the elderly, urbanization, decreased outdoor activities, air pollution and global dining, and age-related decrease in the cutaneous vitamin D production. And lastly, the source of vitamin D in the food are generally too insignificant. In Saudi Arabia, where I live and where I did this presentation, this study, or more specifically in the urban area, such as the capital Riyadh, which is the place where I did this research, vitamin D deficiency is alarmingly high despite of plentiful sunlight and vitamin D fortified food products. In one study, according to one study in Saudi Arabia, in spite of the decreased level of vitamin D deficiency in the patient, it was found that 65% of the participants had adequate exposure to sunlight, and more than 90% of these participants reported adequate intake of dairy products. So vitamin deficiency it was found that associated with many pathological conditions, including osteoarthritis, while sufficient level of serum vitamin D can decrease the risk of many chronic disease. On the other hand, vitamin deficiency can coexist frequently with osteoarthritis and also with obesity in the older people. As regards to osteoarthritis, as all of us know, is the most common chronic arthritis characterized by gradual cartilage loss and also affect other joint structure, causing structural change and eventually joint failure. Vitamin D has many biological functions in this structure by acting on the vitamin D receptors and may have beneficial effects on this joint structure in case of osteoarthritis. Vitamin D deficiency also increases osteoplastic activity and bone turnover and may lead to increased chance of inflammations. So raising the level of vitamin D to sufficient level with supplementation will decrease the rate of bone turnover, suppress the parathyroid hormone level, increase bone mass density, and even decrease the fracture risk in the older population. It was found that vitamin D level influences the incidence and progression of knee osteoarthritis, and it was found in one study that patients with men with decreased level of vitamin D was found to be twice times more prevalent than those with sufficient level of vitamin D. Some studies have concluded that low level of vitamin D in the serum are associated with worsening radiographic hip and knee osteoarthritis, while other studies' results have not proved so. In systemic review for the evidence of association between serum vitamin D level and osteoarthritis, has revealed the following. Moderate evidence for the association between low level of vitamin D and the increased progression of radiographic osteoarthritis as assessed by Killing and Lawrence score, while strong evidence for the association between vitamin D and the cartilage loss was apparent when the joint space narrowing and changes in the cartilage volume were considered collectively as cartilage loss. The author of this review concluded that vitamin D appeared to be implicated in the structural changes of the knee osteoarthritis rather than the symptoms. On the other hand, one study involving patients with knee osteoarthritis has found that individuals who were vitamin D level was low reported more pain and more disability than those with normal level. Obesity is another issue, as you heard from our colleague in the morning. Obesity is defined by the body mass index, 30 or more than kg per square millimeters. It is pandemic and affecting at least 5 million Australians and substantial numbers in most developed countries. If the number of those overweight is added to the patient who are obese, approximately 14 million Australians and about 70% of Americans aged over than 6 years are obese or overweight. In Saudi Arabia, again, based on the National Nutrition Survey of 2007, it was found that about 24% of women and 14% of men were obese. If the overweight also added or included, it was about 30% of the men were overweight or obese compared with 28% of women. The association between reduced vitamin D level and obesity is well established, but the mechanism for the lowered vitamin D concentration are not fully described. But there is different mechanism reported in 2013, included lower vitamin D intake, reduced cutaneous synthesis due to altered behavior, reduced synthetic capacity, reduced intestinal absorption, and lastly, altered metabolism due to reduced activation or increased catabolism. And the last cause is sequestration of vitamin D in adipose tissue. So our study was aimed to evaluate the level of vitamin D in patients with knee osteoarthritis compared with the controls, and also to study the relationship between vitamin D level and knee osteoarthritis. Our study included about 100 patients with symptomatic knee osteoarthritis and age matched to 100 control. All patients under control should be Saudi or non-Saudi who lived in Saudi Arabia for at least 5 years. Control group were selected among subjects who presented to outpatient clinic over the same period of non-musculoskeletal symptoms, or among subjects without any clinical symptoms who presented for check laboratory test. The control group had no clinical features of knee osteoarthritis based on history and the clinical examination. The patients were selected consecutively among individuals who complained of knee pain, who attended the Rheumatology outpatient clinic in Saudi Arabia in Salman ibn Abdul-Aziz University Hospital. The diagnosis of knee osteoarthritis was confirmed by ECR diagnostic criteria for classification of knee osteoarthritis. But we exclude some patients. We exclude patients with other rheumatic disease as inflammatory arthritis, connective tissue disease, hyperuricemia. We also exclude patients who used vitamin D supplement, and those with chronic steroid use, and patients who used intra-articular injection, steroid or hyaluronic acid in the last 3 months. We evaluate our patient by history and the clinical examination, and specific evaluation was for the status of knee osteoarthritis. We evaluate the knee pain and the physical function of these patients. Knee pain was evaluated by using of WOMAC pain subscales and visual analog scales. And the physical function evaluation was evaluated by using of timed chair test, stand test, and 10-meter walking test. We assessed the level of vitamin D, our serum 25-hydroxyvitamin D in both patient and control, and serum 25-hydroxyvitamin D concentration of less than 20 were considered as deficient level. For patients with knee osteoarthritis, we also assessed serum calcium phosphate, serum alkaline phosphatase, serum parathyroid hormone, and serum uric acid to categorize the patient who can exclude it from the study. Patients with knee osteoarthritis, radiography, we did weight bearing, anteroposterior view in full extension and lateral and skyline view, and were assessed by 2 trained observers who were blind to the clinical finding of our study. Radiological features of knee osteoarthritis were graded on 5-point scales from 0 to 4 for K and L classification. For our results, about 70% of the studied sample were female and 30% were men, and the mean age was 52 years, and 66% of these patients were of Saudi nationality. About the control, it was about 53% of them were women and 46% were men, with mean age 50 years old, and 55% of them were Saudi patients. This table represents the comparison between control and osteoarthritic patients, but there is no significant difference between control and osteoarthritic group. About the, concerning the patient with osteoarthritis, 68% of patients with knee osteoarthritis has serum vitamin D deficiency, and 58% of the control has the same has decreased vitamin D deficiency, and the serum level of vitamin D in the patient was 18, while in the control was 19. So the difference in the mean and proportion of the serum vitamin D between the patient and the control were not statistically significant. And also I can't find any, there is association between vitamin D level and the knee osteoarthritis, but was not statistically significant. Among the patients with knee osteoarthritis, 72% of all the patients with knee osteoarthritis were obese, while among the patients with low level of vitamin D deficiency, 80% of them had low vitamin D, were obese, versus 55% of patients with normal vitamin D. But the difference here is statistically significant. About the X-ray radiological evaluation, most of the patients had a mild degree of osteoarthritis. 70% of them has the grade 1 to 2, while only 26% of the patients had grade 3 or more. This table represents the knee pain, evaluation of the knee pain and physical function. There is increase in the pain scores, Walkman score and visual analog scale, a decrease in the physical function representing and decrease the time shared and decrease the walking test velocity. Knee pain scores were high, as I said, as will appear in the previous table. Walkman scale mean was 46, and while visual analog scale pain score was 6. Also, the physical function in this patient, time chair test was 8, while 10-meter walking test velocity was decreased in both selected walking test and fast walking test. The difference in all these parameters in comparing the patient with knee osteoarthritis with those with low level of vitamin D deficiency and those with normal level didn't reach a statistically significant level. Last point is the study the relation between serum vitamin D level and the clinical and radiological knee osteoarthritis, which is the main purpose of this study. There was no significant association or correlation between low vitamin D level and the clinical or radiological parameter of knee osteoarthritis, but vitamin D level was significantly associated with body mass index, where lower level of vitamin D was significantly associated with a higher body mass index by mean negative relationship. As appear in this figure, as vitamin D decrease, there is more obesity. High body mass index was significantly associated with aging, with X-ray severity of the knee osteoarthritis, with greater knee pain, and with slow walking speed. Knee pain measures, visual analog and Walkman subscales, were significantly correlated with each other and with the physical function parameter, time chair test, and 10-meter walking test. Also, X-ray severity of knee osteoarthritis was associated with aging, knee pain measures, and physical function parameter, and both of the X-ray severity and aging significantly associated with greater knee pain, high visual analog scale, high Walkman score, and slow walking speed, and low time chair stand test. So from this study, we concluded that vitamin D deficiency is significantly associated with obesity, which in turn is associated with the greater knee pain, poor physical function, and severe radiological evidence of knee osteoarthritis. But I can't find a direct relationship between severity between knee osteoarthritis, clinical or radiological, and vitamin D deficiency. So our recommendation is we recommend measuring and monitoring of vitamin D level in patients with symptomatic knee osteoarthritis, particularly the obese patients, and also we recommend further studies for the role of vitamin D supplementation in prevention of obesity and progression of knee osteoarthritis. Thank you.
Questions? Doctor, thank you very much. That's a beautiful presentation. Now, you repeatedly saying there are more men with overweight and vitamin deficiency. How come in our experiences, most knee replacement or hip replacement are in women, in the men, a ratio approximately 1 to 3 to 4? Is there any way to explain that?
There's no evidence for the explanation for this, but most of our patients were females, and most of them were obese. Men were about 30% of our patients, so I can't find a certain explanation for this.
More questions?
Another question. Thank you very much for an interesting study. In your experience, it's sort of when you search the literature for having correlation between vitamin D deficiency and BMI, is there any other published evidence which shows otherwise from your results?
There's many
Yeah.
literature published this. It was written below. Many studies approved this. This relation between vitamin D deficiency and obesity. It's well known in many literature.
It's surprising actually, because you would find it the otherwise. You'd probably think vitamin D deficiency would probably be not a problem in obesity because people probably stay in the sun and lie in the sun, not doing very much. But anyways, probably is. Okay.
In Saudi Arabia, for example, among the factors you mentioned that create low vitamin D, do you think also the nature of the clothing that precludes the absorption from the sun and aging as well, even if individuals are exposed, the aging process reduces the sunlight. So it helps when you're younger and obese, but as you get older, lying on the beach in the sun doesn't help.
There are two main reasons for the deficiency of vitamin D in Saudi Arabia. The first one, is very weather there. Even the men,
Yes.
even the child
The clothing.
cannot go to expose their body to
So
sun.
the culture.
Other cause is, as you said, is the clothes and the culture of this country.
All right. I think, is it possible that you are looking in the study, but it doesn't have enough power, statistical power, to demonstrate significance? Was there any trend that would support a hypothesis? Because there's a lot of information about, yes, moderate effects, but when you look at bone health and vitamin D and bone health and osteoarthritis, there's reasonable evidence for vitamin D being helpful, as well as vitamin D in terms of cartilage viability.
All this, but I can't explain all these studies in my presentation, but there is many studies which is improved the very good relationship between the vitamin D level and knee osteoarthritis, but other studies deny this completely.
Right, but it's possible maybe your sample size didn't lend itself to finding a trend. Maybe there's not enough variability in your sample or something along those lines.
Another proceeding, but I can't use this in my hospital. Many studies use
Another methodology. All right, very interesting.
Thank you very much.
All right, are there any other questions? All right, so thank you very much, Professor Mohammed.